everyone. I hope you're all having a wonderful day. My name is Nida Mariam, and I'm the coordinator of Alfaisal MedHub under the International Office at Alfaisal University, Riyadh, and Saudi Arabia. I'd like to welcome you all to yet another exciting webinar under the Career Guidance Series, UK. For those of you who don't know, Alfaisal MedHub is an initiative under the umbrella of the International Office at College of Medicine that aims at creating an online global community of medical students. Alfaisal MedHub covers a broad range of topics that are common to medical students all around the world. Our primary objective here at Alfaisal MedHub is to help medical students learn more about the career opportunities available after graduating, as well as the steps that are involved in pursuing them. Since medical students are always confused about the path that's ahead of them, Alfaisal MedHub's Career Guidance series addresses this challenge from the perspective of accomplished and experienced seniors. As you all are aware, we are now conducting the Career Guidance Series UK for all medical students in partnership with AMBOSS. We are excited to introduce you to Dr. Abdullah Alshammari, who will be delivering the third webinar under the Career Guidance Series UK, titled Surgery Specialty Talk. Dr. Abdullah obtained MBBS in 2014 from Alfaisal University and a Master of Science in Experimental Surgery from University of Alberta, Canada. He then worked as a teaching assistant at College of Medicine, Alfaisal University, and was a surgical scholar resident in thoracic surgery at KFSH. He also holds a master's degree in public health from University of Essex, UK. His interests extend to medical education and community advocacy of healthy living. He has published many papers in several renowned journals in surgery, medical education, and public health. Moreover, he has presented in several prestigious conferences and has led several community services projects. Thank you for joining us today, Dr. Abdullah. We are looking forward to this exciting webinar. And please feel free to share your screen when you're ready.
Thank you very much. And thank you all for having me. And nice to see so many familiar names. Okay, so this is the technically outline. What are the different specialties in UK and what statistics looks like from 2021 match, pathway, how to get into surgery. I'll talk about the exams and what do you want to do to maximize your chances. I'll talk about that. I'll talk about different pathway of getting into consultant job without it. We'll have an overall view of the surgical training in total. What do you want to do? How do you want to improve your portfolio as a trainee? Application process, and then frequently asked questions in terms of surgery and other specialties, and I will touch base on that. Probability of training consultant post after training. Yeah, I'll talk about that as well. Good. Okay, so more or less I am covering everything. So we have two types of registration. I know Abdullah and Lean already spoke about that. So you have something called provisional registration with GMC, and you have full registration of GMC. What's the difference? Provisional registration, well, it allows you to be an to start an F1 job. F1 job is like an internship. So if you have not completed an internship, then you can apply for a provisional registration with the General Medical Council. You have to have passed both parts of the PLAB test within the past 2 years, or passed an acceptable overseas registration clinical exam. I will talk about that in a minute as well, because they do accept some other exams from US and Canada. The full registration, there are few ways to obtain a full registration with GMC, either passing PLAB test, as we all know. You can be sponsored by a GMC approved sponsor. I will get into that in a minute. I'll open the website and show you what does that mean. And acceptable postgraduate qualification is the route of MRCS or MRCP. Acceptable overseas registration exam. Any of these exams are accepted by the GMC. And again, it's a case-by-case thing. So you have to apply to know if they will accept yours or not. So in general, yes, in theory, but GMC are the ultimate authority to decide would they accept or not. But this is from their website. So they accept USMLE if you passed step 1, step 2, the CK and CS, either on or before the 13th of March. So if you have done that, I know some of you may would you say why I didn't go to US if I already passed that? Some of circumstances will prevent people from going to US, especially with all the political issue happen. Sorry, 1 second. Yes, hello, Abdullah speaking. Okay, sorry about that. And relevant European qualification, it's not applicable for Alfaisal, so I'll leave it. Many people who have graduated from any residency within Europe, they are immediately accepted for a full registration with the GMC without any examination. Eligibility for entry into specialty or GP registrar. I'll leave this. There is a slide. I'll talk about this. This is called the CSER pathway or certificate of equivalent registry to the GMC. So overall, the surgical training pathway is divided into uncoupled or coupled pathway. The uncoupled or the old pathway, where you have to finish the medical school, finish 2 years of foundation training, then you have to do core surgical training or general surgery. Then you have to apply again for national matching, and then start a higher specialty training in your respective specialty, regardless. Since August 2000, or starting from 2019, 2020, and last year, August 2021, there was a committee called Improving Surgical Curriculum Committee, where they have made most of the surgeries run through training program. So you start from ST1 or from year 1 with your respective specialty all the way until ST7 or ST8. 1 minute. Apologies. Okay. Any questions so far? Come pop in the chat before I go on. Any questions about registration? Any questions about the concept? I want you to understand this concept because all my talk, whether it's surgery, radiology, or anesthesia, it's all based on this concept. So you have to understand, coupled is more competitive. I'll show you statistics in a bit. They are both competitive regardless. And I'll show you how to become competitive or to compete with UK or European candidates. It's not impossible. Okay, so the run through is shorter than the normal route. No, it's not. It's just based. So the run through is you are guaranteed that you are through the same specialty from year 1. The coupled or the uncoupled program, you have to apply twice for the specialty. So you apply as ST1 or CT1, and then you reapply after you finish the core training for a national selection as at ST3 level. How do we get GMC sponsorship? Yes, okay. Okay, GMC sponsorship. So I hope you can see my, so if you go to the website, you need to, so there are few areas or few institutes that have authority to sponsor you or to give you GMC sponsorship. So if you go to registration and medical registry licensing, then you can types of registration. So for registration, and then those are the multiple ways of registry within the General Medical Council. So sponsorship by a GMC approved theme or scheme. So you have, they called multi-international theme or scheme with any of these institutes. And if you copy paste any of these and search it, you will find their website, what is the eligibility criteria for each independent trust or foundation or college and respective specialty, or whether it's radiology, psychiatry, so as pediatrics, the MTI scheme. So most of them are MTI scheme. The only issue with most of these schemes that they are mainly for higher educational training rather than junior or early registration training. So they prefer people who have done more than 3 years or have more than 3 years experience within their respected specialty. And then you are only there for a couple of years or 3 years and you want to go back to your specialty. Many registrars from India, Pakistan, Gulf, some European countries, they will come through this route and then finish 2 to 3 years to go back. It's like a fellowship, then go back and become consultants in their country. And some of them, they do sponsor the whole training scheme. It's again based on each institution criteria. And can we do internship in the UK? So doing internship in the UK as an international graduate, it's possible, but it's not recommended from what I hear from all the international students, because it's difficult to get into the foundation program as FY1 compared to getting in as FY2 or as a senior house officer or a junior clinical fellow. So if you finish your internship in Saudi or in any other country, it will become easier and it's more regulated. You can do a FY1 and FY2 in UK. It's not impossible. It is a bit difficult, but many of the international students here, they do recommend finishing your respected internship in your own country. Okay, any other questions? Was that clear, or should I repeat anything? We have a very long talk, so I hope everyone got their coffee, and I'll give you 5 minutes break in between because I know I am gonna talk a lot. Okay. So those are the different surgical specialties. I'm gonna leave ophthalmology towards the end of my talk. Those are the major subspecialties in surgery. Most of them, they are now run through specialties as a trial, as a pilot since August 2021. Yes, okay, sure, Salim, thank you. We'll keep the questions toward the end. So between sections, I'll give 5 minutes for questions. So those are the main surgical specialties in in the UK, they used to be uncoupled. So you used to start as coronary surgeon, then at ST3 you start any of the subspecialty, except for neurosurgery, cardiothoracic, and ENT or otolaryngology. They were run through since 2019. Since 2021, most of them now are run through training. So as I said, those are 3 already approved. Since 2021, those are have been piloted as run through training program, plus the core training or uncoupled program. So you have 2 ways to get into each of these specialties, either as a run through program or as an uncoupled. So you finish core training in general surgery 2 or 3 years, then you apply as ST3 or ST4, depends on the specialty, or you go straight from ST1 or ST2 level and go through with your specialty. And this is another scheme of how the training is divided. So you can, after finishing the foundation year or internship and finishing 12-month post-graduation in your respected specialty, you do core surgical training, then you apply again for ST3 or ST4, and then you finish or run through from ST1 to ST7. You can do in between academic clinical training or research. I will talk about that also towards the end of my talk. You can do it either before you start the training. You can do it in the middle of your training. It's your choice between it's an agreement between you and the deanery and your consultant, or you can do, this is more academic based or degree based, let's call it master or PhD. You can do experimental programs or thesis with diplomas, not really a degree per se, not a master or PhD. And it's all acceptable, and it counts or it adds to your training program. Some of them will accept doing it alongside your training, so you can do it if you have time. Many of them will not. They are very particular about the working hours. But again, it's an agreement between you and your supervisor, and then whatever makes you both happy. So this is the statistics from last year. So how many applicants and how many posts available and the competition rate. So in cardiothoracic surgery at ST1 level, there was 113 applicants. There were 16 posts across the whole of UK in the 4 countries, England, Scotland, Ireland, and Wales. The competition ratio is 18. So you are competing with 18, okay, for each seat. At ST3 level, again, it's 23. Sorry. This year, ST3 for cardiothoracic has been removed because there is no more cardiac surgery posts as consultants. So they removed that. They replaced it with ST4 positions for thoracic only. This is where I applied last year. The core surgical training, as you can see, you are 4 per seat. There has been 2,000, almost 2,500 applicants with 600 posts. Neurosurgery, same thing. You have 16 applicants per post, 59 for ST2 in neurosurgery, the ENT 5 to 1. So competition is high, but again, it's doable if you do the right thing. Plastic surgery. I'm not sure, they didn't put it in this, but I can look it up for you. But again, they will be within the same scheme with the cardiothoracic and neuro, more or less. Okay, so back to the scheme. Again, I want you to keep this picture in mind because this is how the training program will go. No ortho. Ortho and trauma, they are there. Sorry. Ortho and trauma. This is from 2021 again, because this year, where am I going? This year they just approved August 2021 again, all those run through programs. So the statistics are now based on the previous classification. So trauma was not a run-through. Trauma is newly a run-through program, an orthopedic. It used to be core surgery, then trauma. So most of the surgical specialties, the competition is here. Okay. Again, it's since August, August of last year, 2021, the whole system has changed based on the new curriculum. Sorry. Okay. Foundation training. Again, if you are a non-European or UK medical graduate, then you have three options. Either you can have foundation training outside, foundation training inside, or get into the UK foundation program. Getting into the UK foundation program is the hardest among them because they barely are accepting the UK graduates, and there are a lot of graduates. So accepting you, it's going to be a tough job. So what we prefer is you finish any of your equivalent or our internship in Saudi and get the CREST form signed under your supervisor. And then you can complete 3 months either in Saudi or in UK afterwards and get the CREST form signed. You can also start as a non-trainee doctor when you come into the UK after getting the GMC through either pathway. Start as an FY2, start as a CT1, start as a junior fellow, start as a house officer, get your CREST form signed within the UK, and then apply for training. And I believe Lean already spoke about the CREST form in detail, so I'm gonna skip this part. And it's self-explanatory form. So if you find, once you are downloaded, it's really self-explanatory. What is approved criteria for a non-UK internship? So you have to fulfill this checklist. So you have to have a minimum of 12 months containing medical and surgical 3 months rotations. It has to be between 12 and 18 months, and at least 6 months in medicine and 6 months in surgery if it lasts for 18 months, or 3 and 3 if it lasts for 12 months. If you fulfill, any of this checklist, then voila, you have your internship is accepted. So our internship from Alfaisal is accepted. Now, many of you will say, oh, I have only 2 months in medicine. We do an Alfaisal. Anything that's considered medicine is any of this: nephrology, cardiology, even pediatrics is considered medicine. So you are covered. We don't cover 3 months in surgery. Yes, you do. Any ER, any urology, any ENT, ophthalmology, anything is considered surgery. Okay, you have 2 electives and 2 selectives. I believe this is still the case in Alfaisal. So those are counted towards your surgery or towards your medicine. 3 months. What about gaps? Many of you or who has been doing exams took some gaps, and they wanted to maximize their internship to 18 months. So their certificate is issued at a later time, so there is no gaps. And again, if your internship is total and 12 months, you have to go through the checklist again. And no one can tell you the GMC will not accept. Again, it's the ultimate call of the GMC to say yes or no. So you can always explain why you had a gap. You can always phrase it in a nice way, and they will always accept if there is a valid reason. And you will always have a valid reason. I can barely think of anyone who would have a gap and not provide a valid reason. And you can always sugarcoat your reason in a nice way to make it valid. Okay. Bottom line is GMC is the ultimate authority to decide if even you have gaps, that your internship is still valid or not. So first job in the NHS. Start at one point. It's all about networking, because at the end of the day, once you have your GMC, then you will easily find a job within a month or 2. So start with internship, observership, clinical attachment, doesn't matter. When I first started, I came here for 2 weeks observership, and I got my job after. It's all about how you show yourself, come in, show them that you are committed, you are an added value to the organization, you want to work there, you have what it gets to be in the NHS. Even if your papers are not yet ready, tell them you are working on it, and you will get it. So observership, you don't need to have a GMC registration. You're just there, you're shadowing, you're not in encounter with the patient, nothing. So you can do this. If you are coming for PLAB 2 and you have an extra time, you already got your visa, you can contact any of the trusts with your respected specialty. Many of the consultants are very welcoming and acceptable. They love to have students around. So through the NHS job, if you find job opportunities, and there are always contact person and a doctor who's responsible for that post, try to contact doctors, approach them. They are always welcoming. Do the extra mile, go the extra mile, and you'll always find your way. Once you have your GMC registration complete, you can start applying for a non-trainee job as well as trainee job. Trainee job process opens at a certain time. I'll talk about it in a minute. Non-trainee job runs throughout the year, so you can find a job at any point of the year, and you can start that. You can start towards your 3 months at least to sign your request form if you want, or start your 12 months experience post-graduation at any point, and then work towards fulfilling all the points that we will talk about for your training application. So as I said, there is a person specification required for each job. Study these requirements carefully. Try to fulfill it while you are still in Saudi as much as you can. And I'll come to each point again. All specialties have specific criteria for entry. I'll run through the website, and I will send the website to all of you for each specialty. What are the specifications for each specialty? They are almost a copy paste among all specialties: medicine, surgery, OB-GYN, pediatrics, anesthesia, radiology, all almost copy paste, 90%, except the 10% where there is procedure differences or special things regarding one specialty over another. Those variations are 10%. But if you fulfill the 90%, you are ready to be a trainee in the UK, regardless of which specialty you want to enter. So, core surgical training, 2-year program, 4 to 6 months rotation in different specialties, whether it's A&E, accident and emergency, trauma, orthopedics, general surgery, upper GI, cardiothoracic, also part of core surgical training. Any specialty you can go through within your first 2 years. Some of the doctors or trainee who are not ready yet to apply for ST3, or they think they haven't fulfilled the criteria for the second application through the national application match. Sorry. For higher training at ST3 or ST4 level, they can continue for CT4 or core trainee level 3. So CT stands for core trainee, ST stands for specialty trainee. So when you hear CT1 means core trainee at level 1, ST1 to ST7 specialty trainee at any level 1 to 7. So you can have CT1, CT2, CT3, then apply for ST, or you can have ST1, ST until ST7. The core surgical training, unlike internal medical training, they have a big catch. So when I'm talking about surgery, anesthesia, and radiology today, this is a big catch in each application. You cannot have more than 18 months experience in surgery, radiology, or anesthesia to apply for ST1 level. If you have more than that, you cannot apply at ST1 level. Okay, So you have to always keep that in mind, because this is the catch where it becomes tricky. So you cannot overdo it, and you don't want to underdo it. You want to really balance to apply at the right stage at the right time. So remember this whenever you want to apply for surgery, anesthesia, or radiology. This prevented many junior doctors from applying at ST1 or CT1 level, and they had to work as non-trainee for a few years before they can apply at a higher level at ST3 or ST4 level. So bear that in mind. Or if you already have more than that, again, you wanna know how to organize your evidence to show how much you have done so outside UK in terms of experience in your respected specialty. And again, this is mainly clinical experience, not academic experience. So if you have done, let's say, 3 years of academic/clinical, it's only counted as 50%. So 3 years will count as 18 months. 2 years will count as 1 year of clinical experience. What is the reasoning? That doesn't make sense. I am not the one putting the rules. Okay, it's a rule. Okay, I don't know what's the reasoning. Maybe you are overqualified. To them, you are considered overqualified if you have done more than 18 months in certain specialty. Again, it's not my call. It's just a big rule, and you cannot overcome that. It's a big catch in each application for at a level 1 of these specialties. So you have to be careful in applying to show where are you or where do you stand. Criteria and shortlisting. I'm gonna share this. Okay, so I'm gonna share cardiothoracic because, or let's say, let me share first the core surgical trainee. Can you all see my screen? Yeah. Sorry, I'm not, yeah, okay. So these are person specification. This is from 2019. There will be not including foundation module, even if more than 1 year. So the foundation is so outside foundation, yeah. If your foundation is 2 years, it's as 2 years as within the UK, that's not counted. So it's postgraduate 18 months. So do not exceed 18-month post-graduation, not including your internship. Internship is a side, okay? So it's post-internship, 18 months. Is that clear? What if you have done some core training for oral and maxillofacial surgery? Again, I cannot speak on behalf of the committee who review your application. So if it's for core surgical trainee, then they will consider any type of surgery. If it's for specific surgery, they will consider specific surgery 18 months. So for me, cardiothoracic, I could not apply if I have more than 18 months in cardiothoracic surgery. For people who are doing orthopedic, they cannot, or trauma, they cannot do more than 18 months in trauma and orthopedic, and so on and so forth for any other specialty for now, as of 2021, because they are becoming run through specialties. If you are applying for general surgery or core trainee, you cannot do more than 18 months in general surgery, regardless what type of surgery it is, because there is oral maxillofacial, ENT, neurosurgery, they are all under the umbrella of surgery in UK. They are not different as in Saudi or in UK, or as in Saudi or in US or in Canada. So surgery is surgery. Neuro, ENT, oral maxillofacial, pediatric, all under the umbrella of surgery. So based on your specialty or your choice of specialty, you have to be careful what or how to apply or how to prepare your evidence. Okay, application. personal specification for applying at a CT1 level. So qualification, and I think already they talked about EPIC verification, Abdullah and Lean. So this should be already fine. You have to have full registration with GMC. We already spoken about that. So eligibility, that where it is. Fitness to practice, that you are a safe doctor, and that's from your application and your examination. Language skill, I believe already Lean and Abdullah talked about IELTS and OIT, and so on and so forth. It's all self-explanatory, and how the evidence is obtained for each one of this and how they evaluate it. Okay, so either through the application or through the interview. And again, 18-month or less experience in surgery, not including foundation module. It's a big catch. And they always highlight that. So be careful when you apply for surgery for that point specification. And then here where you can have more points, so you can see what is the essential criteria, what is the desired criteria, and when they evaluate each of this. So qualification, essential is your MBBS. Desired criteria if you have additional qualification. And in surgery, it's better to have it surgically related or related to your area of interest. So I did experimental surgery. It was an added point for me in the application. Public health, it is just a degree, but it was not counted as much as my experimental surgery qualification. So if you are willing to do an extra master, or you still have time to do it, or you still are building on your application, and you have the money, you have the capacity, you have the willing to do an extra degree, then choose wisely what degree do you want to do, and it has to be relevant to your specialty of choice further, because it's counted towards that. Don't just waste your time, do it smart. If you want to do a master, then it has to be worth it. It has to be counted for you as knowledge and for your application later on to enhance your chances. Clinical skill and knowledge, they love courses in the UK. So as much courses as you can do related to surgery, just do it, okay? And always keep evidence, always keep evidence. It's all about evidence. It's all about providing evidence. Keep your evidence available. Whatever you do, keep an evidence of what you do, okay? This is how you prove you have done it. If there is no evidence, as if it's not done, regardless, okay? Evidence can be a letter, certificate, anything that's signed, that is authentic. Skills, research, and audits. How many of you know what audit is? I think none of us have covered that. I didn't prepare a slide for it, but I'll just put a note so I can speak about it till then. How many, can I know, anyone knows what audit is? You can unmute yourself and speak.
Hello?
Yes.
I think it's like what we conduct in our university as a problem and how to improve it and what the solutions they are for a specific problems that healthcare is providing. Healthcare system is facing. So you diagnose the problem and you tell what it is and how to improve and how to make it better. Something like that.
Yeah, more or less, yes. Okay. But in summary, or as the definition in UK, so you are evaluating. So there are different types of audits, but the general idea is, let's say, quality improvement audits. Those are the most common ones. But you have clinical audits, you have operational audits, blah blah blah. There are different types of audits. Most importantly, the clinical and quality improvement audits. Yes, exactly. Comparing current guidelines or current practice with established guidelines. So whatever you are doing at the moment, so let's say we're gonna introduce, so in thoracic surgery now we are doing an audit. We wanna do blood patch, which is taking blood from the same patient injecting it through the chest drain into the chest of the patient to stop air leak. Okay, so this is a new practice. There is few research out there, but there is no official guideline. So we want to start an audit comparing our practice to the international guidelines or unestablished guidelines for air leaks in patients. This is one type of audit. Let's say if you are in your case, or make it to more simplified, you are establishing the documentation of patient notes in your department compared to a standard way of writing notes, SOAP notes, as international way of writing notes. So this is what audit is. Audit, and it's not popular in other countries. It's very popular here in UK, but you can consider anything you did at the hospital as a local experience, or at university as a local experience, and then you have improved upon it as an audit. An audit has two parts. Part one, where you introduce the intervention. Part two, where you evaluate your intervention and how that improved your practice. So there is a loop and a closed loop. The first loop is when you introduce the intervention. You identified the problem, you introduced the solution. Part two, when you close the loop, you introduce the solution, then you evaluate your solution, and then you close the loop. So did your intervention actually work? So what would be the evidence of an audit? So it can be a letter from your supervisor who supervised your audit. It can be that the audit was published, or you presented that audit in anywhere in the university, you presented in a public health. Yes, you can present public health day. Dr. Bara is doing right every year. Public health day, you can have certificate, but you have to have a description of that audit. Get a letter from whoever is your supervisor doing that. Or if you publish that audit at any journal, locally or internationally, regardless, because it can be a research. So audit at the end of the day is a research, but it's a local research. It's on your own department, your own institute. It's your local experience. Technically, that's an audit. But again, you are comparing your practice to an international guideline, or to a published guideline, or to a national guideline. And you are comparing your practice. So they love audits. So audits and research is also part of your application, and it counts. Having prizes and awards, distinction, presentations, national, internationally, they count towards points. So there's a scoring system, and we'll come. I'll show you where you apply. And there is a way to score yourself, and then they will score you based on your evidence, and then they will compare your scoring to their scoring, and then they will give you an average score. And then based on that score, you will be ranked through the application. Teaching. If you teach BLS, if you teach anything, okay? Again, it's evidence. So if you teach at PBL, if you teach at any of the MSA courses, if you taught, I don't know, reading club, whatever, okay? It's counted as teaching, okay? Any experience in teaching, again, with evidence of feedback for teaching, okay? From your students, from MSA, from the university, get an evidence. Communication skills, leadership, you can put any type of leadership you have done. Leading a group, being a MSA head committee, being a batch leader, being I don't know, cooking club initiative, whatever, okay? It's leadership at the end of the day, okay? Describe it, put it in a nice way, in a leadership position. Preferably it's related to medicine, okay? Yeah, cooking was an example. It may pass, but again, make it more medicine related. Organization, planning, leadership, all values, same thing. Professional integrity, again, from your interview, that will be evaluated. Commitment to specialty, again, how much you have done in terms of surgery courses, how much extracurricular activities you have done. Did you organize conferences? Did you attend conferences related to surgery? They count. Are you a member of any surgical society, or have you been attending any of the meeting, blah, blah, blah. Again, evidence, okay? It's all about evidence. You need to know how you score, okay? You need to be smart in application. Don't do stuff that will not count for you. Do stuff that will count for you. Again, I know you are doing it because you love to, you are interested in it, but do it smart, okay? Do stuff that you want and you love, but that will count towards your application. Don't do stuff that will not count. And I hope I'm clear in that. I cannot be more clear. So that's surgery. If you look, the same thing about cardiothoracic, and it's the same thing. This is 2020. So that one was from 2019. This is 2020. Again, it's exactly the same thing, copy paste. What will be different is just everything will be, they will just remove general surgery and they will put cardiothoracic, okay, in the same application. So here, everything is related to cardiothoracic. So it's the same exact applications, the same exact copy paste personal specification, but I'm just going to remove general surgery. I'm going to put cardiothoracic. It's the same for neurosurgery, same for maxillofacial surgery, same for plastic, same for everything. When you go for ST3 application, which is now, it's done. The last year was 2020 for ST3. Now from 2021, they did ST4 for thoracic only. And again, almost the same, but here we have the extra thing is career progression, where you have to show how much you have done in terms of cardiothoracic surgery training, how many cases you have done, and how much you have done on your own to be at ST3 or ST4 level. Again, everything else is the same. Okay, research audit, personal skills, communication, leadership, all blah, 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 same thing. Okay, so this is in general what they are looking for. So I will share this as well, and I will share the link where you can download all these documents, and I will show you where you can find them. And again, this is all from the NHS website, and you can find personal specification, and you need to try to focus. This is where you need to build your CV. This is what they are looking for. So you need to know what they are looking for. You need to give them what they are looking for, to tell them that you are at that level, okay? Because all what they have now is your application. They don't know you. They don't know Ahmed. They don't know Salim. Even if you are the best surgeon in the world, you are the best candidate. But on paper, this is what matters. You need to show your worth on paper before the interview to make it to the interview, because this is where you can be shortlisted. Then at the interview, you will show your real self. But evidence is what will get you to the interview. And if you don't get to the interview, no one will know about you, okay? So no matter how much you put in your CV, if it's not related to any of this, it's worthless, okay? It's not counted. So know where you want to put your energy on. Okay. Is orthopedic a run-through specialty right now? Yes, since August 2021, you have two ways. Either run-through, as I said, it's now a piloted run-through program curriculum, and they are still doing a core surgical uncoupled pathway. So all the surgeries are run now in two ways, either run-through or as uncoupled through core surgical training. So you can go through it through two ways. Until this gap is filled within the next couple of years, then they will stop doing the core training pathway, and they will make everything run through. when we can apply for a run through specialty. It starts from November. I'll come to it. Hold your horses, Salim. So either apply to CT1 or ST1. Exactly. Either CT1, then you do 2 to 3 years, then reapply again at ST3 level, or you start from ST1 or ST2 for some specialties, and you finish all the way until ST7. Is that clear? Am I clear in this? That's why I kept saying, keep that diagram in mind. Graduate in 2024. I have no idea. Okay. I want to live until 2023 for now. Then we'll see what 2024 holds for us. After FY2. After FY2, you can apply for either CT1 or ST1 as of today. Again, curriculum may change next year. It has been changing since 2019. A lot of changes happening since 2019. The improvement curriculum committee has been making a lot of changes to the surgical curriculum since 2019 at a junior level, at a senior level. Do you have any info on UK MLE and how that will change the system? Unfortunately, I don't. And again, it's an evolving system. Even the people doing it, they are still not knowing how it will end up. Okay, so it's in progress. It's still unclear. Like we had in Belfast last week a meeting with the curriculum committee, and they are still in the process themselves. They are not really understanding the whole situation. They are still developing the program. They want to see how it goes. Okay, so this is not the final picture of the whole program. It's evolving. And it's the first trial piloting the run through among all specialties this year. So still, we are still yet to see how that ends toward the end of the specialty or the end of the trial for now. Okay. Switching gears to surgical ophthalmology. So in surgical ophthalmology, you don't need to do the member of the Royal College of Surgeons exam. I'll speak about the exam in the next slide. It's called ophthalmic specialty training. It's a run-through program from ST1 to ST7. You need to have to pass 3 different exams other than surgical exam. It's called FRCO, Optha 1 and 2, and you have to have a refraction certificate in between, and it's a totally separate program. Medical ophthalmology is under medicine, it's not under surgery. So if you want surgical ophthalmology, it's this one, or ophthalmic specialty training. Medical ophthalmology, it's a totally different pathway through the internal medicine pathway and MRCP pathway. And you'll have 4 ophthalmology year of training after you finish the core medical training in medicine. And I think Lean can touch base on that. I'm not going to touch base on the medical stuff. The membership of the Royal College of Surgeons, the MRCS exam, it's 2 parts. There is a knowledge, experience, competencies, and I will talk about a lot about competencies in the next few slides toward the end of my talk, because it's all now about from the moment you start your training until the moment you finish with your fellowship of the Royal College of Surgeons exam. It's all about competencies. So how you progress from one year to another, it's not based on exams. There is no exam between years. So you don't proceed from level 1 to level 2 based on exam. No, you proceed based on your competencies. So every year you'll have a meeting with your supervisor. You have an educational and a clinical supervisor, and they evaluate your competencies. So you have an agreement at the beginning of the year on objectives you need to achieve by the end of the year. And you're less like you have to do certain amount of cases, you have to discuss certain amount of diseases, management, blah, blah, blah. And then you need, by the end of the year, to achieve these competencies, and you'll be evaluated on how you perform throughout the year. Okay, and you have to log all your evidence into our website, and I will show you the website again in the next few slides. Sorry. So MRCS exam, again, you can do it while you are in Saudi now after you graduate. It's a one way to obtain GMC registration, or you can do it after you come into UK if you have done the PLAB and you have obtained your GMC and you are starting your surgical post. MRCS used to be a plus point when you apply for CT1 or ST1. It's not anymore a requirement, and it's not counted as part of your matrix when you apply for trainee or junior training job as CT1 or ST1, but it's a requirement, a mandatory requirement if you apply for a higher training job at ST3 or ST4 level. Sorry, what's the question? Is there a priority to local graduate like the US? In what sense, Ala? Do I need to do MRCS in addition to the Ophtha exam? No, MRCS, if you are doing ophthalmology surgery, MRCS is not your thing. You are doing the FRCO exam. You have nothing to do with MRCS. Getting into CT1, no. US exams will only get you registration with GMC if GMC accept your USMLE examination based on the criteria I showed you, but has nothing to do with CT1. CT1, it's all about personnel specification criteria that I just showed you. It's all about, you have to collect points on that. And they're scoring points, it's published on the website. I mean that it is a negative to be an international, no. Once you have a GMC number, then you are equal. So whether you are a UK or international, they will treat you equally because they have this big rule about no racism, no difference in treatment, all this in the NHS. So you have the exactly same opportunity as everyone applying. It's all about your scoring system. So this is what I'm saying, but the thing is, the advantage of the UK graduates, because they are familiar with the system, so it's easier for them to fulfill the system. While you are as an international student, it's difficult for you to fulfill the system. And that's why we keep saying, come in and start working as a non-trainee to know the system, to know how to get into the system, to know how to fulfill the system. You want to do it smart, okay? If you are outsider, you will never be able to understand the system. You cannot really fulfill it in the same way. You'll always have a gap and you'll always fall behind in terms of scoring. That's the only advantage of UK graduates over international graduates. It's not because of the race. It's just because you are more familiar with the system. Yes, you can come after internship. Get your GMC. So the first step is getting your GMC. Once you get your GMC registration, all doors will open for you. You can do anything you want. Finish your internship, get your GMC registration, and that's it. Okay, then you come and start. Non-trainee, trainee, everything will open for you. GMC registration is your door. Okay, so Part A exam runs usually 3 times a year, January, April, and September. It's 300 MCQs, 180 applied basic science, 180 minutes, then you have 30 minutes break, 120, which is called post-operative surgical general knowledge, and it's mainly about management. Will it affect someone negative to work in hospital admin? Okay, let's keep the non-surgical for now. Those side questions, keep them in mind, write them down. I need to run through this, then I will get all your questions, guys. I just need 10 more minutes to finish this topic, then I can get all your questions. So part A is 300 MCQs. Again, my best source, if you have to have a knowledge, so EMRCS and past test are the best ones. Past test has, they have a books and question bank. EMRCS is the biggest question bank. EMRCS is the best question bank for part 1 of part A, which is the paper 1, or they call it paper 1. Paper 1 nowadays is divided into 2 sub-papers, so 90 and 90, and they have 15 minutes in between. I did the older version of the of part A. So the new version is 90 and 90, and they have 15 minutes in between. Then you have 30 minutes break, then 120 questions, and it's now online. You can do it from home or in a center with a laptop. The best way to study, hoping that you do have the basic background, is do questions. Do questions, and you will get a feedback, or you read the explanation after the questions, and whatever area you feel you are weak at, go and read more about it. Okay, so you can solidify your knowledge. And again, they know that those are the main sources for people studying for the exam, and they are not changing the concepts. The concepts are the same, but the questions change. So don't memorize the question, memorize the concept. Know the concepts very well. They always ask about more or less the same concepts throughout all the exams. Okay, 70% of the concepts are almost repeated. They recommend it's difficult to do both parts of MRCS before getting a non-trainee job, given the lack of exposure yet. So part A is not difficult to do it before getting the job because it's knowledge. You have knowledge or you don't have knowledge. Part B, it's a bit tricky because a lot of it's based on communication and UK way of communication. It's not any communication. You can pass, many of people passed, and you can do it actually outside UK. So MRCS is run in many countries. So you have MRCS centers in UK and Ireland, and you have in Oman and Bahrain and Egypt and Sudan. They run the MRCS exam. So if you want to do it before coming to UK, do it in a non-UK center, because at least you are evaluated based on an international average, not based on a UK average. Because the way part B, I will talk. Okay, let me get to part B. I'll get to part B because part B is the issue in terms of if you want to do it before coming to UK. But part A is clear now. It's 300 questions, 90, 90, 120. It's mainly, so part A or paper 1, it's about anatomy, physiology, pathology, 180 questions, multiple choice, single best answer, then 120 questions based on management and interpretation or surgical application afterwards. So that's, sorry, the 3 papers of part A. Part B exam runs again 3 times a year, February, May, October, 19 stations, 9 minutes each, 3 stations for anatomy, 2 pathology, 3 critical care, 3 physical exam, 2 history, 2 communication, 2 stations for the communication, and 2 surgical skills. There is nothing wrong with you doing it before coming to UK if you know the system. This course, this is an Egyptian doctor, he's from Medina, and he runs an online course. There are so many similar courses, but this is the one I did and I recommended because I believe it helped me a lot in passing both part A and part B. In part A, after doing EMRCS and MRCS, get into any of those courses where they will discuss all the previous exams based on recalls. Recalls are people, once we get out of the exam, we memorize all the questions that came out and we discuss it. So it's similar to what you do in med school, okay, when you have the previous exams. So those courses, there are so many in Facebook, and you can find them in WhatsApp. Indian, Pakistan, Egypt, Saudi, Bahrain, Oman, they have so many. And they collect all the previous year's questions and stations, and they discuss them. So towards the end or towards your exam, last 6 weeks of your revision, or last 3 weeks at least, get into one of these groups and start revising all the previous stations and previous exams. So it will help a lot, okay, to pass or ace your exam. And I recommend Dr. Salah. It was, so if I want to apply to CT1 or ST1, I have to do MRC. No, first of all, we are surgery, so it's MRCS, okay, no offense, okay, but we are surgeons, so it's MRCS, not MRCP. That's one. And nowadays, CT1 or ST1, it's not a requirement to do MRCS. It's not. They removed that from the requirement since 2020. So there is no longer need for MRCS as a requirement for ST1 or CT1, but it is a requirement for ST3 or ST4. But if you're gonna do it and just get it out of the way, just do it, get it out of the way, because you have to do it one way or another at one point, okay? It's like a residency, it's not counted. It's a matrix, so it's all points. So nobody will look at it, because when you apply, it's all matrix, it's all points. So it's not there. They will all count the points. So focus on the points. If you have time to finish it before coming, then finish it. If you don't have time and you can improve another area where they will count points on, then do that. Okay, again, be smart, apply smart, see where they count the points and do that. Don't waste your time on something that's not going to count for you at the moment. If you have an extra time and you feel your CV is well enough and you are ready to apply and you have extra time, you want to do the exam, do the exam. If you can improve another area of your CV, do that first and apply. MRCS, you have 3 years from the moment you start your training to do it, and you can do it in 3 months. Okay, part A, you need 3 months to revise part A, and you need another 3 months to revise for part B. It's not difficult. You just need hard work. I'm being blunt, sorry, we are surgeons, okay? I'm being blunt, okay? Just do it. Don't fluff around, because nobody will care what you're doing. They just want to see points. Specialty training is, as I said, if it's a run through, it's from year 1 to year 7. In the previous definition, it was from ST3 until ST7. So if you are applying at ST3 level and you have not been through the training before, there is another certificate called Certificate of Readiness for higher educational training that need to be signed. You have to complete MRCS before you apply at ST3 level or ST4 level in some specialties, and then you can start your specialty training. In the previous model or uncoupled module, there is a national application at ST1 and there is another national application at ST3. So it's not automatically if you finish CT2 or CT3, you are going into your specialty. You need to apply again to go to specialty training. Okay, that's it if you are doing uncoupled module. If you are doing the run-through module, that's it, okay? From year 1 until the end of your training, that's it. It's one application, you are through towards your graduation. But for if you are doing, sorry, the uncoupled, then you have to apply twice, one at the beginning of your residency and one in the middle of your residency at ST3 level. Then once you finish your training, you will have your CCT, certificate of completion of training, and you have to do your FRCS exam, and then you are a consultant. Okay. FRCS exam, again, 2 parts. Sorry. Okay. Thank you very much. For coupled, since it is one application only. No, you don't need it at the beginning, but you cannot progress to ST3 without MRCS. So this gonna be part of your evaluation, of your yearly evaluation at ST2 and ST3. You cannot progress to ST3 or ST4 without MRCS at that point. So your committee or your deanery will not promote you to ST3 or ST4 if you start a run through without MRCS. Multiple research projects or audit add more points, or one of each is sufficient to fulfill the requirement. So it depends on the scoring system for each year. So in my case last year, I applied as ST4. They needed 5 audits, and they needed 5 research projects as a first author, not case reports. Okay, so for me to get the full scoring system in these areas, so I needed 5 audits in the audit section, and I needed 5 research papers published for me to be the first author in each of these papers, and none of the paper has to be a case report. Case reports are not counted. So again, and this is for ST4. So for ST1, I believe it's less than that. It should be a 1 and 1. I need to double check the scoring system. But it is published, and you can have a look at it. And I will send you all the websites to look at the scoring system and the specification. Okay. And again, sorry. Then once you finish the FRCS, you become a consultant. I'll speak in a bit about the CSER pathway, or Certificate of Eligibility for Specialty Registration. They call it CSER pathway or Article 14 pathway. It's another way to become a consultant without being a trainee. And many European doctors and many international doctors have gone through that. But recently there are a lot of claims or calls to try or start to minimize CSER pathway, and they are replacing the CSER certificate with CCT certificate, because many of international countries did not recognize the CSER certificate, and many consultants couldn't become consultants because they had the CSER certificate rather than the CCT certificate. And this has been a big issue in Saudi, in UAE, and I know in Egypt as well. Review papers. So as long as it's a published paper, not case report, and it's indexed, PubMed indexed, okay, or indexed in general, then yes, it's counted. It's 1 point. And depends how much point they give for each section. At each level is different. So they will obviously need more points or more. They don't accept case report. Case report is not counted. So don't waste your time doing case reports if you are applying. It looks good in your CV. I'm not sure at ST1 level, sorry. I need to double check ST1 and CT1. But for me, it was not counted. I'll try to have a look at the scoring system now with you. I can search it on Google. Yes. So first author is more desirable. You'll get more points being a first author. Being a co-author is counted. But being a first author is as a plus in the application. And presenting that is another is another area. So presentations is another area, and whether it's national or international, it will give you more points if it's international conference. So presentation, publication, they are two separate sections. So you can score with the same thing twice. So if you publish the paper, no, they don't have to be specialty specific. But again, specialty specific will give you a score on the commitment to surgery, and when you do the interview. So when you publish in your area, that will show you are committed. Where yes, personal specification, when we say, oh, commitment to specialty, then you are interested in that specialty. You have published, you have been more interested. So that counts later in the interview, but not in the scoring system itself. Okay, so in summary, what you want to do, again, GMC registration is the main goal for now, okay? And then for me, I see this as a big point. You have to adapt to the NHS system by doing a non-trainee job. You can do a trainee job from the start, it's up to you, but for me, I think it's easier and it will way smooth your application if you do a non-trainee job. Come, see how the system works, maximize your chances, maximize your points, and then apply for the training job. Competencies, you will hear this word a lot when you are in the UK, whether you are a non-trainee or a trainee doctor. Competencies, competencies, competencies. You have to fulfill the competencies. What are they? Set of knowledge, skills, abilities that you need to, you need to prove that you have achieved these competencies at each point of your training, okay? So if you are going from level 1 to level 2, you have to show that you have achieved certain competencies at that respective level. There is no way you can bypass the training and get the certificate without proper training or evidence that you have fulfilled the competencies, whether you are a trainee or a non-trainee. You will not be able to sit for exams or to get at the end of the day your CCT or Caesar. Caesar is now they replaced it with CCT since 2020 or 2019 actually. So you cannot get your CCT without proving that you have fulfilled competencies. Whether you are trainee or non-trainee, you have to make sure, or you have to prove that you have fulfilled competency. So even if you are non-trainee, you cannot bypass training because you have to prove that you have fulfilled the competencies as a trainee. Can you take 2 masters at the same time? Again, why do you want to take 2 masters? Will this add to your points? If yes, go ahead. If it's just a waste of money and time, don't. Will those 2 masters help you in achieving any goal? If yes, go ahead. If no, then no. Okay. You don't need another piece of paper to put it or to hang it on the wall. Okay. You need something that will help you. If it's something you really are passionate about, by all means, do it. If it's something for the application, do it smart. Do it where it will help your application. What if you are a dentist from UK and have done hospital job? So many dentists, there is now, I don't know the details, but dentistry and maxillofacial surgery, they have a common pathway. So if you've done dentistry and there is an exam for dentistry, I think they accept that exam to go for maxillofacial surgery. I don't know the detail. It has been changing again between 2019 and 2020. I haven't gone into details, and I'm sorry, I can look into it, but I'm not really aware of all the details between dentistry and maxillofacial surgery. This is the only common pathway between surgery and dentistry is maxillofacial surgery. Other than that, you need to do the whole thing again. If you want to do any other type of surgery, then you need to start all over. But the only cross between surgery and dentistry is maxillofacial surgery. And I'm not aware of the details because maxillofacial surgery, dentistry are doing a special exam, and I think it is acceptable by maxillofacial surgery committee. But again, you need to look into that. Don't take my word for it. So evidence. So if you want to start as ST1, CT1, you need to have evidence of foundation competencies, CREST form. If you want to go for a higher education, you need to have evidence that you have fulfilled the core surgical training competencies. So it's another certificate called Certificate of Readiness for Higher Educational Training. You have to pass the MRCS and boost your profile if you are going for higher educational training. If you have time and you have fulfilled all the other areas of your portfolio, then get the MRCS out of your way so you can focus on your training later on. Get other specialty specific criteria fulfilled, okay? Have a look at the person specification and see what exactly they are looking for. Be smart, be smart, be smart. I cannot really emphasize on that more. Academic training and research. Again, for you, Ala, okay? Even a master in skateboarding you can take, okay? Will that make you a good trainee? No, okay? Do the things that will help you in training. So there are two ways of doing academic training and research. Academic clinical fellow, I am doing this with NIHR fellowship with Imperial College. So you can do it based on your specialty. I'm doing it with lung cancer thesis. You can do master or PhD as well out of your training. Many of my friends, they took a 2-year gap. They did statistics. They did master of surgery. Again, each one based on their goal and what they are looking for. Pros and cons. Pros, it will give you a better job as academic clinician at the end. It will give you a different perspective. Many now are calling for academic surgeons. For the future, it will give you this academic prospect of a clinician. It will give you a gap in your training. So this is part of the cons, that it will delay your graduation or becoming a consultant, or then because you are taking a gap in your training from surgery, whether it's 2 years for masters or whether it's 3.5 years for PhD. You can do a part-time PhD or part-time masters, but again, you are considered doing 50% clinical and 50% academic. So again, it's prolonging your graduation both ways. Financially, NIHR help with some scholarships. If you have a good proposal, they can support you up to, I think, £5,000 per year. Depends on the university you are going for. International fees vary. They support masters as well, again based on your supervisor and university and NIHR, how they can support. Those are the main supporters of NHS or Educational Health England for academic training. You can find other scholarships, but they are not directly related to Educational Health England. The main sponsors for academic sponsorship are the NIHR or National Institute for Health Research. I'm not sure how many Saudis are in the audience, but UK and Saudi in 2019 and 2020, they started a collaboration to send students or postgraduate student to hire residency programs in Birmingham, mainly. I think this agreement in many specialties. They had 300 seats in 2019 and above, or until now. Sorry. I'm not sure how many in medicine. I haven't had any cardiothoracic surgery or someone in cardiothoracic surgery I'm aware of at the moment. This is the portfolio and how you collect your evidence as a trainee, and as a non-trainee also. If you start, I suggest you start building up your portfolio. I'm gonna show you mine. So again, ISCP is your main website for getting any information regarding anything related to surgery. Okay, the curriculum, the person specification, anything you want. This is the portfolio. This is the main website where we all put our evidence, where we all provide our evidence. So keep this website, save this website in your browser, and for any information regarding to curriculum. And this is the pathways now. This is the recent changes in any pathway. So pediatric, again, you have uncoupled and run through ways to get into pediatric. Same thing for plastic. They changed everything almost now to be the same since August 2021. Vascular, plastic, urology, all the training pathways became coupled and uncoupled, okay? Except for neurosurgery, because it has been approved since 2019. It's run through only. There is no core surgical training for neurosurgery. It's only run through. This is all the curriculum. So again, you can see any curriculum you want. I'll go for general surgery. Again, this is the new curriculum. You can see everything you will study, all the competencies you need to achieve at each point of your training, how many surgeries you need to do, what are the topics covered at each year, what are you evaluated upon, how many cases you need to do, all blah, blah, blah. The full curriculum for each specialty. This is the new updated one as well. So this is done. I want to show you. So this is my account. So when you go to your account, this is your portfolio. So you need to have all of this each year. Sorry. Each year, I need to do at least one audit. I need to do multiple case-based discussions with my consultants based on common topics in thoracic surgery. I need to do consent. This is not now needed at my level. At a junior level, you will need a lot of consents and physical examination. Direct observation of procedure. It's whether you did part of the procedure or full procedure, it's all in there, and you need to fulfill it and to write about it. Multiple consultants report at the end of each year. This is how you progress. So the consultants, your clinical, you have supervisor. You have two consultants supervising you. One called the clinical supervisor and one called educational supervisors. And then they will meet with you at the end of each year, and they will evaluate you to either promote you or not promote you based on your performance. Multi-source feedback. Each year, you will have around 10 to 15 clinical staff evaluating you from nursing, from pharmacy, from junior colleagues, senior colleagues, and they will all evaluate your performance, and it's part of your overall evaluation. Teaching every year you need to do. Let's see, this is how many I have logged in. I'm not up to date with my logging because I'm not yet threatened. My meeting is still far away, so I am chilling at the moment, which is a bad habit. Don't do that. And then self-assessment, you do self-assessment. One thing also I want you to keep an eye on, it's e-logbook. So this e-logbook is where I log all my operations, and it's counted toward the end, and they need how many operation you observed, you assist, you did with supervisor scrubbed, you did with supervisor unscrubbed, and you performed personally with supervisor not even in theater, and how many operation you have been teaching. So this is again what I have logged so far. It's already, I'm gonna come into your question, not this one. And it's already synced to the e-logbook website, which is the website for logging. It's an international website to log any surgery. So if you want to start at one point now in Saudi before having ISCP, and if you are interested in surgery and you have observed or assisted in any surgery, create an account in e-logbook. Keep your logbook there. It's part of an evidence that you can keep, and you can show that you are committed to surgery. You have assisted or you have observed this many surgeries. So again, this is my e-logbook. Browsing operation. Let's see. And so I can do any, let's see, it's just logging in. So this is which specialty you are doing. You can put it in patient ID. You can, at the end of the day, when you export your evidence, you can anonymize all this. So this is the information of the patient, blah, blah, blah. I did the surgery. My supervisor was scrubbed, but I did the surgery. What is the surgery, which part of the surgery was done, and where did I do this? As you can see, some I have, since I created this, I was in Saudi, so I have some done in Saudi and some done at Brompton, and this is the operation note for me, and I just update it. Keep this evidence just for you. If you are planning a career in surgery, this is something that it will count toward you, whether at a junior or a senior level. This is part of your commitment to surgery. Bad habit. Shukran, Abdurrahman. Yeah, I know. Sorry. We can log observed surgeries during internship. Yes, you can. So here at this, you can see observed. So you can change your status, the supervision status from, for me, supervised trainer scrub. You can do it observed. Okay. You can put all the observed surgeries you have done. And then at the end of the day, you can popularize it and sign it by your consultant before leaving Saudi, just to keep it as an official evidence. So those two websites are the main websites for surgeons or any surgical trainee here. And again, e-logbook, you can either add it, you can add from ISCP website, or you can add from e-logbook, and it will sync into ISCP. Either way, it's fine. Okay, enough of that. And let's go back to this. So again, and throughout the curriculum, you will see how many, sorry, did I miss any question? We can, yes, okay, I didn't. So throughout in the curriculum, it's already explained at each level how many you need to log per year, and it's again based on your agreement at the beginning of the year between you and your supervisor, the clinical and the educational one. So you are agreeing on certain number of cases, you are agreeing on certain number of procedures, you are agreeing on certain number of discussions, and so on and so forth. And then you need to fulfill this by the end of your year, and it's how much you accumulate toward the end of your training. Because in thoracic, you need to fulfill 250 major cases by the time you graduate as a consultant. So how many procedures do you do from day one until the end of your ST7 without supervision? You have to finish 250 major thoracic case unsupervised to become a consultant. And this is part of how you want to fulfill it if you are taking a non-trainee route. So you have to fulfill the same competency as a trainee to be eligible to sit for the MRCS exam, to be eligible to get the CCT certificate and become a consultant in the UK. Okay. Again, this is what I was talking about. If you are taking a non-trainee job, then this is a Caesar pathway or Article 14 pathway. So again, you need to, you are an international medical graduate, you are doing another 12-month internship overseas or in UK, depends on where you are. You are doing a non-trainee job, you can do it for 8 years, 9 years, 10 years, doesn't matter. What matters is you need to gather your evidence and fulfill all the competencies as a trainee or even more than a trainee to be eligible for the exam. Then once you are sit for the exam, then you can become a consultant. It's not impossible, but it is difficult. The difference between a trainee and a non-trainee, they both can reach the goal, okay? Based on how determined you are and how organized you are. The only difference is that trainee, they are well supervised, they are organized, the path is there. There are set goals, there are set competencies each year. It will make your life much easier. And consultants are there to supervise you. And it's most of the trust, they will support the trainee because they will support the trainee in achieving their competency over the non-trainee. So if you are a non-trainee and there is a trainee at the same level and you both want to do the same thing, the trainee, most of the cases will have a priority over the non-trainee, okay? But again, it's not always the case. They do support non-trainee as well, but it's a case by case, okay? So don't count, oh, I can do it as a non-trainee. It is a bit difficult. It will take you a lot of effort, time, and you have to be very determined because you are doing everything on your own. Nobody is supervising you. Nobody is guiding you. If you want to do the Caesar pathway, you are on your own. And there's no guarantee by the end of the 7th year that the GMC will accept your evidence. And they will ask you, oh, give us this evidence. And if you are not gathering your evidence on a timely manner, then you are losing a lot. And you have to go gather evidence from what? 3 years ago, 4 years ago, it's gone. It is the difficulty, but I have known a lot of European doctors and international doctors who became consultants through the Caesar pathway. It's not impossible, but it's not easy. Yes, any job is a paid job. There is no unpaid job in UK unless you are observer, and that's different story. But as long as you are part of the NHS, a trainee or a non-trainee, you are paid. Okay. So what if I don't get into training? So you have Caesar pathway or Article 14, and you can always enter without foundation or without doing any non-trainee job. But again, I don't recommend it. As I say, acclimatize yourself with the system to do it smart. It's highly competitive, yes. It's not impossible, okay? Surgery everywhere is competitive, no matter where you go. But if you are determined and you want to do it, it is not impossible. It is possible. If you are ready to compete and beat, then you can do it. And I know Alfaisal have prepared you all for that. And you are all ready to compete international students and beat them easily. If I could do it, you easily can do. Again, this is comparison, the CCT or Caesar. Again, now the certificate is CCT, it's not Caesar anymore. But many countries now are aware of that. So if you don't, they will need an evidence that you obtained CCT as a training, as a structured training pathway rather than non-trainee. Not in UK. I'm saying if you want to go work outside UK, then the countries differ in terms of accepting the Caesar pathway certificate. Some of them will accept you as a consultant. Some of them will not accept you as a consultant if you do it a Caesar pathway. So just be aware of that toward the end as a long-term goal. Okay, before I go to radiology and anesthesia, any questions before we switch gears? No, Saudi does not accept Caesar. Saudi never accepted Caesar. So you have to do a CCT pathway. Saudi needs CCT, and you have to prove that it is, because now CCT is done through both ways, Caesar and non-Caesar. Saudi needs it to be through a training pathway. They will not accept non-training. Recommend double applying. I'm interested in both IR vascular surgery, for surgery and radiology in the same year as a backup. You can, if you are fulfilling both, you can apply. It's your choice. But they will always, you need to prepare an answer of why you are applying for both and what you prefer to do, because you're going to rank your preference. Again, it's what you want to do. It's not what I'm going to do. I cannot speak on your behalf. It's what you are passionate about. What's your long-term? Let's talk about radiology, and then you may change your mind after knowing all the aspects of it. Organ transplant specialty. No, it's a fellowship. After you finish any of the surgical specialty, you can do another year of transplant after finishing ST7, or between ST6 and ST7, you can do a fellowship in transplant. Probability of obtaining a consultant post in the UK after training. Again, based on availability. So the reason why they stopped doing ST3 cardiac surgery in our case, because there are a lot of cardiac surgeons who don't have job yet. So a lot of cardiac surgeons graduated with no jobs available. So again, it's based on the jobs available. If there are consultant jobs available, you can become a consultant. If there are no jobs available, you're gonna stay as a registrar, senior registrar for a while until you become a consultant, or become a locum consultant at one point. If it's okay with you, could you kindly walk us through the timeline of what you did before getting your post? Okay. So I had a very weird story. Anyway, I studied for USMLE 2014, but I didn't want to go to US. I studied for my Canadian exams. I got a post in 2017. I didn't go because of Saudi-Canadian issue and because of my personal issues. And through that time, I was doing my academic residency 50-50% with KFSH and surgery, and I was mainly focusing on thoracic because of my academic interest. And then 2019, I applied for a clinical attachment here in UK. I got it. I had an interview, and they offered me a clinical fellow job. I took the job, and I was lucky. The institute is part of the sponsored scheme, so I got my GMC approved. I did my MRCS exams 2019, 2020, and I saw all the criteria. I was doing research, audits. I did all my cases because I cannot apply as ST1 because I did more than 18 months in Saudi for surgery. So I was not eligible for a junior job. So I applied for a senior specialty post. And last year, it was the year where they started doing ST4 for thoracic surgery. So I applied for that. Clinical attachment. It's like shadowing. It's like you come here with a consultant, you ask them to that you want to come for a month, or in my case, I did just 2 weeks, just to see how the system works, to get experience by observership. Clinical attachments, it's similar as observership. Clinical attachment is directly through a consultant. So you need to find a consultant and ask if you can do a clinical attachment with them or through the department. So that's either through NHS job website or search in the websites. Does having a connection contributes into getting the competition specialties like Imperial, blah, 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 or it's a national based on just your point? So connection doesn't work in the specialty because it's point system. The points will get you the interview, and the interview will get you a job. So connection at the level of shortlisting won't help because they won't get you into the interview. It's all about points at the first stage. Maybe at the interview, yes, because you will know the people who are interviewing you, and then it may help or may not, but there are 5 interviewing you. So, and you are getting the average points of 5 consultants. You did academic fellowship with KFSH. What is that exactly? Okay, it's I was teaching assistant plus a resident, so I was doing half teaching assistant and as a research coordinator for thoracic department in KFSH, plus doing surgery as per the curriculum. It is not something popular, and I'm not sure if they do it anymore. KFSH had changed the rules a lot lately. So it was an arrangement between university and thoracic department. I'm happy overall. Yes, I am. I love thoracic and I love surgery. Can I do a PLAB 1 during internship, or I must finish internship to get my graduation certificate before applying? So again, technicality of that, I'm not aware of it, but I believe, I'm not sure, is Alfaisal issuing the diploma now before internship or issuing the diploma after internship? It's all based on which paper you can provide, and it's part of the acceptance. In 2014, we were the first batch, so I had 2 separate certificates from Alfaisal. One that I finished my 5 years medical education, and then another certificate that I finished my internship, and then the overall diploma. So I had 3 different papers actually. When did you do the master's? Between 2016 to 2017, I did my master in Canada. 2018 to 2020, I did my master's here in UK. Any questions? Any more questions before we jump? Yeah, my master in UK was part-time. Technically, it was online because of COVID. So yeah, it was in my advantage. That's the only benefit I got out of COVID. Okay. Good. You can unmute and talk because don't waste your time typing if it's easier. Okay. Jumping into radiology, I'll go through radiology and anesthesia very quickly. It's mainly more or less the same concept, but in a different way. And then I'll leave the floor for any random questions. Okay, so again, radiology it's a run-through program. It's not coupled uncoupled program. It's a run-through program. Recruitment happen at ST1 level only. There is no recruitment at a higher level training. They are now speaking about recruitment at ST4 or ST6. But again, it's not well structured. But if they have some openings, they may open 1 or 2 seats for ST4, ST6. But again, don't count on it because it's a year by year thing. They may announce or may not announce higher training jobs. You can add, there is only one fellowship in radiology in UK, which is interventional radiology. So you can add 1 year after the 5 years to do interventional radiology. And then how you develop your specialty, it's toward the end of your training between ST4 and ST5. You can have a special interest in any of subspecialty of radiology, pediatric, musculoskeletal, vascular neuroradiology, and so on and so forth. And again, all in any specialty, whether medicine, gynae, radiology, surgery, anywhere in UK, you have the 2 different pathway, either CCT or Caesar pathway. So you can become a consultant in one way or another. Again, the same issue in all of them, structured and unstructured. You need to have your evidence and competencies. Oh, yes, of course. I'm sorry, Mohammed. You can have 5 minutes. Actually, I need 5 minutes because I have been coughing a lot. 5 minutes and we'll be back. And I'm happy to accept any questions. We'll go back. Dear guys, are you happy with 5 minutes break? Sorry, I know I have talked a lot. Okay. I don't need to feel that I'm speaking to a computer. You can all unmute and speak.
I think everyone agrees with a break.
Okay, sure. Yeah, let me know when you're ready.
Salam, Doctor. I think 5 minutes passed. If you're okay, we can start.
Yeah, sure. Okay. I just quickly downloaded for you guys shortlisting for ST1 cardiothoracic. So I'm gonna share that. Can you see this?
Yes, we can.
Okay. So this is the scoring system for ST1 cardiothoracic. Again, similar will be for any other specialty. But for me, it's easier to get all cardiothoracic documents because I'm there. So this is how the scoring system goes. And each domain will get you 1 point. Again, section 1 is always about MBBS and your qualification before. So the training post held and career progression after graduation. So again, you get 0 if you have exceeded 18 months in training post outside cardiothoracic surgery. So you don't get anything. Evidence of satisfactory career progression, including training post in one of the following specialty, either vascular, trauma, plastic, but less than 4 months in cardiothoracic surgery, that's 1. If it's less than more than 4 months in cardiothoracic, and total of less than 30 months in training posts as CT1, 2, or foundation excluding foundation training. Sorry, you get 2 points. You don't get any point. The maximum point you can get is 2 in this category. So it's all, again, self-explanatory, and you can see where you need to score and how much you need to do. evidence you need to provide. So undergraduate medical career research, audit, prizes, awards. So you can get 3 points if you had national award or national prize, recognized academic or clinical excellence. If you had presented in any conference and you got award, it's counted here, national or international. So you get 3 points, full points. And here they didn't mention specific number. So 1 will get you 3 points. 2 or more distinction is an undergraduate, you'll get 2 points. Or first class honor in final degree, you'll get 2 points.
So that means Dean's List, Yani?
Yes. Again, higher degrees, MD or PhD with a clear relevance to a career in cardiothoracic surgery award. So again, the degree you have, you do, if you want to get the 3 points, you need to do it in relevance to cardiothoracic or neurosurgery, if it's a neurosurgery, or vascular, blah, 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 same thing. Any bachelor degree you did outside MBBS and you have done some career in respiratory or cardiac, that's a 1 point. So if you are doing a degree that has nothing to do with cardiothoracic, it's not going to be counted. Okay. This is what I'm saying. So it has to be all relevance to the specialty you're doing. So Ala, when you are asking, oh, I want to do double major, why? What's the point? You're not going to get anything. The maximum you can get is 3 points. So 1 master, relevance to your specialty, it will get you the maximum point in this area. So don't waste your time, don't waste your money. Other degrees and diplomas, here, postgraduate diploma you can have, again, full-time research, teaching service in cardiothoracic surgery, again, relevant to the specialty. Postgraduate research, if you are doing any role in research, or you can provide any evidence as you are author, co-author, or part of a committee, again, it's an evidence, you can provide it.
Sorry to interrupt again, but
yeah.
You mentioned, why do 2 masters, but above it says 2 or more postgraduate diplomas.
Diploma is not master. Diploma is
what does it exactly mean?
Diploma in UK, there are something below master, and they give you a diploma about it. So it's not a full degree. It's I don't know how to describe it. It's a sub degree of a master. So the diploma, if you finished 1 year with certain modules in the master, you can be awarded a diploma, but you are not at a level where you are awarded a master. You need, so let's say a master in public health مثلا أنا سويتها في عندك 16 module you have to finish to fulfill master degree. But if you do the core 8 or 9 modules, you can be awarded a diploma.
Clear. So if you only do 1 master's, you won't get points in this section.
No, you already got a point in postgraduate higher degree. So you already got it. So you do another master, when حتحط البوينت.
Okay.
And to think as انت الحين you are fulfilling an electronic systems, huh? You are uploading evidence and you are scoring based on electronic thing. You're gonna upload 1 or 2 evidence and you have to score it. The maximum score you will get is 3, صح? And you already uploaded 1 master. طيب الماستر الثانية وين ما ايش حنسوي فيها؟ ما حنلف فيها شاورما، ما فيها شيء. It's pointless.
Clear.
Okay. But for you, if you are doing it for you, you are passionate about it, you want to do it for your own sake. زي اللي قاعدين يسووا statistics, my friend, because they want to do it. They want to be academician. They want statistics. By all means, do it if it's for your own good, for your own sake, for your own passion. I'm not saying I'm not being pessimistic and I'm not depriving you from education. No, do it. But if you are doing it for the sake of the application, do it smart. Okay, know what they are scoring and like fulfill the criteria here.
So sorry, just to be clear. So if it's A3A and A3B, those are shared. They're not separate.
No, they're separate. They're separate. انت في النهاية هنا they are separate في الpoints. هنا 0 to 3, 0 to 2. This is separate points. بعدين at the end of the day you're gonna count maximum score available 36. If you want to calculate كل هذه الpoints, you are scoring out of 36 points. Yeah.
So why would you still get the points for A3B?
You're doing another diploma, صح؟ هنا you're not doing a full master. You're doing a diploma.
Okay.
So هنا one postgraduate and postgraduate diploma you can do it online. يعني في already what you call it في educational website حق NHS. Once you become a part of any NHS trust, whether you are trainee or non-trainee, you will have access. There is mandatory training and there is optional training. And for optional training في عندك access to online surgery modules. It's online modules. You can finish it or they will quiz you على كل module. And by the end of it, يعني أنت تقدر تسويها على راحتك within the 3-6 months you are doing, and you will be awarded postgraduate certificate online. It's free. It's from the NHS. It's from your trust. It's free for anybody working in NHS.
So in that case, doctor, just to clarify, I asked, if you did a master's degree, I would only get the 3 points.
Yes.
And if I did no diplomas, I would lose on 2 points since they're separate sections.
Exactly.
Okay, so I do have motivation to do diplomas.
You do have, what do you mean?
I do have motivation to gain more points and do diplomas, especially since you mentioned it's free.
ايوه انا قاعد اقول لك do it, بس again ما تيجي تقول لي انا حضيع 6 شهور I'm gonna waste 6 months doing a diploma while انت ما عندك ولا point من الباقي sections. Do you have clinical audits? 3 points. Do you have publication? 3 points. Do you have presentation? 2 points. So are you gonna waste what I'm saying? Be balance. Where do you want to score your points? Where do you want to put your effort? Okay, there's no point in that you are wasting 6 months على 2 points while you are not fulfilling the rest of the 36 points. Balance. Where do you want to score and how much are you scoring out of the 36? You want to get as much scoring as you can. This is what I'm saying. I'm not saying don't do it. Do it if this is the only thing that's preventing you from getting 36 out of 36. But I'm not gonna, if this 2 points will make you 12, so what's the point? Go focus on something else that will give you 3 points easier. Clinical audits, you can do it in 2 weeks. So you can do it actually less than that. Leadership, you can create a committee and you can, I don't know, create a course and do something and be a leader. Chair a national and international committee. Get the 3 points. Yeah.
Clear. Thank you.
Yeah. Okay. Again, teaching, formal teaching, anatomy demonstrator, teaching a skill, major communication or teaching. Again, they count it. Again, it's based on the evidence, how you are providing your evidence. Maximum is 2 points here. Surgical procedure, operative experience. Accident procedure and operative experience for career level indicated strong commitment to acquisition of clinical skills. So again, this is what I was saying about e-logbook. Okay, how many cases you can do, and you can compare yourself to the curriculum. So see in the curriculum how many cases is done at each level, and tell them, I have done observed, or I have participated or assisted in so many on this and this and this and these cases, and I am more committed to surgery. It's 3 points, and it's nothing. If you are interested in surgery, any consultant you are working or observing with is happy to sign it, log it for you. Personal statement, it's 1 point. Again, your statement is either going to be good or shitty, and I think Lean already. Did she share with you her personal statement? just make sure it's well written and it's directed. And I can also share with you my personal statement. As a medical student, yes, you can do it as a high school student, e-logbook. You need just to open an account, and it's a free account. Just create an account and start logging your information.
Does a TA job count as commitment to teaching?
Yes, it's a formal teaching. Again, get letter from the university. You have been a TA. My TA letter was part of my evidence for me commitment to teaching. So I provided that as one of my evidence. Okay, so this is where for each specialty, this is where you wanna, this document is your guide on where you wanna focus throughout your job when you start or when you are preparing for application. So the shortlisting for each respected specialty. And again, it's online, it's on the website, you can download it, and you can then plan ahead how you are going, where you are going. And again, be smart, be smart, be smart. Okay. Okay, back to our topic. Is it clear?
Yes.
Good. Okay. Okay, we talked about radiology. We said it can be CCT or Caesar pathway again. Again, statistics-wise, sorry, question. Yes, okay, thank you. Question, statistics-wise, radiology, again, it is competitive. If you're gonna compare it to core surgical training, it's almost as competitive as core surgical training in terms of how many applicants per seat. So you have almost 4 applicants per seat application. Again, the statistic from last year. There is the recruitment assessment or the process through the Royal College of Radiology. And anything you want to have information about the specialty or its application or the documents or the shortlisting, it's through the Royal College of Radiology. So you have to pass the SRA exam or SRA specialty recruitment assessment. This recruitment assessment is assessment for all specialties. It's since 2016 has been a rule that medical, GP, anesthesia, and radiology, they go through SRA or there is MSRA exam. And Lean will talk more about it in the internal medicine talk, because it's mainly related to the medical specialties. SRA, why they are very important in radiology, because the scoring is a big portion of the selection criteria when they choose candidates for the specialty. It's almost 1/3 of the selection criteria is based on the scoring in this assessment exam. And again, as I said, it's similar to the MSRA exam for GP trainees. It's a similar concept, but it's a different center. Again, why they are separate, I don't know. It's just different royal colleges and different sitting exam, so they can have their own unique assessment. So run through, you have 3 years of general training, then 2 years of specialty training, and throughout the special interest training, you can develop your special interest based on the subcategories we already identified before. And you can have a separate 1 extra year of interventional radiology. Similar catch for radiology as in surgery, you cannot have more than 18 months in radiology to apply as ST1. If you have more than 18 months, then your only chance, if they open a higher specialty post, that you can apply for it at ST4 level in that year, or you can carry on as a non-trainee radiologist. So again, it's a big catch in radiology, big catch in surgery, big catch in anesthesia, as I will come to anesthesia. You will have the FRCR exam, similar to the MRCS exam, but this is more for radiology. You have first and last part. The first part is done throughout your junior training years, and the second part is done throughout the end of your training before your FRCS exam or FRCS certificate or CCT certificate. You have part A examination and part B, again, knowledge-based and practical-based. So the knowledge-based, based on all areas of radiology, cardiothoracic, musculoskeletal, GI, gynecology, pediatrics, CNS. And the part B is, they call it long cases or intermediate cases nowadays. They prefer to call it 20 minutes each station. And then you will have a case, and they will discuss the case with you in details for 20 minutes. Anesthesia, again, Royal College of Anesthetists run the training program. So all guidelines and information regarding the specialty from their website. You have 4 levels of training in anesthesia, basic or core level, intermediate level, high level, and advanced level. The area or training of anesthesia can be you can be specialized as ITU consultant afterwards, pain management, or post-hospital emergency emergency medicine. The competition, again, similar to surgery, almost to surgery and radiology, with almost 4 per post. It's it's uncoupled training, so you have to start at CT1, then reapply at ST3. You have to do the FRCA or the anesthetic exam in between. This is how you started. There are 2 ways of starting at a junior level. So you can start CT1 with the focus on core anesthetic training, 2 years, or you can do the acute care common stream, which is common for internal medicine, emergency, anesthesia, and ITU trainees. Finish 3 years, then start at ST3 level. This is if based on which you choose or which area you choose, it will prolong or reduce your length of training. Again, why people choose one over the other? Because many trainees may not know what they want at the beginning, so they go for the common stream, and then they choose later on what they want to do, whether ITU or anesthesia or emergency, or maybe they will go back to internal medicine. Or if you know from the beginning you are anesthetist, then you can go from core anesthesia training. But because they have common modules or common rotations between them. Again, the same catch, less than 18 months. The foundation competencies signed through CREST, same thing. What is the acute common stream? Again, it's a 3-year alternative training program. If you want to have a higher trainee in internal medicine or acute internal medicine, anesthesia, emergency, or ITU. Again, mainly those who are not yet settled on what they want to do. They choose this common pathway, then they choose later on what they want to do. They have the common modules of emergency medicine, internal medicine, and intensive care. Intermediate level, you can apply for it at ST3 level. Again, it's another national application. You have to have achieved the CT2 competency, and again, sign if you are not trainee, you need to sign the certificate of readiness for higher educational training. And at advanced level, At this time, you can choose where do you want to specialize, either ITU, pain medicine, pre-hospital emergency. Again, same thing. You can always do it as a trainee. You can always do it as a non-trainee. You need evidence. You need to make sure you are providing all evidence for competency. So to sum it up, in any specialty you do, whether it's my talk today, Lean's talk, Vikram's talk, any specialty in UK, more or less they are following the same concept, okay? There's CCT pathway, there is run-through or uncoupled pathway. Whether you want to go for one or the other, look at the person specification, look at the shortlisting, fulfill whatever you are missing from these points, and focus on that, and then apply. Acclimatize yourself with a non-training job. This is my advice, my personal advice. Again, you know your own personal circumstances, and you know where you lack and what you want to develop and build, and then go for it. Any questions? Finally.
Can you briefly explain what non-training jobs are?
So any non-training job is a trust-based job. So if you are a house officer, if you are a clinical fellow, those are mainly, so junior clinical fellow, senior house officer, clinical fellow, those are all names for non-training job. So you are not part of the training. So you are a trust doctor. So you belong to the hospital. So your contract is based on the hospital, not based on the deanery. So the education system, or the system for doctors in UK, there are trainee and non-trainee. The trainee belong to deanery. Deanery, they are let's consider them as provinces. So London Deanery, or Manchester Deanery, Liverpool Deanery, and so on and so forth. So London Deanery, all trainees that train in London and its borough or its areas, they belong to a big hub called London Deanery. So your authority or your direct manager is the deanery, the whole deanery. And the deanery is part of the Royal College. But as a trust doctor, your authority, your direct manager is the hospital, your direct hospital. It's not the deanery. The deanery supervise multiple hospitals, while a trust doctor belongs to the respected hospital. Does that make sense?
Yes, thank you.
So you can, one of my junior colleagues recently, she applied for ST1 and she was not accepted. And she doesn't want to exceed the 18 months because she wanted to apply for cardiothoracic, and she already spent with us a full year. So she applied for an ITU job. So she started now an ITU job for her not to exceed the 18 months. But again, you need also to fulfill the other points of the specialty you want. So if you want to start, you need to have a balance between starting a job with the specialty you need to fulfill the points, but do not exceed the 18 months for you to be able to apply as ST1 or CT1. So make a balance between you want to fulfill the points, score high in the matrix, plus do not exceed the 18 months. I hope that answers it. So whether you start as a non-surgery or start as a surgery, doesn't matter, as long as you make sure you can fulfill the scoring matrix. Guys that speak, I don't like, I need to feel people alive. I get a job offer not for my first choice. How do I know it's time to settle and accept it? As a job non-trainee or as a trainee?
As a trainee job, if I'm applying after FY2 doctor, and I applied for multiple specialties, and I got a job offer, but not for my first choice. And I don't know how many points is necessary for they requested for the job.
Right.
So when do I accept the job or wait till I hear maybe a job offer from a different specialty?
Okay, so mostly all specialties, they open and close at the same time. So the opening and it's a different web. So it's a different website. It's an Oriel website. I'll show you. They open all of them. They open November, late November, and they close late December. It's almost 6 weeks window, 6 week to 8 week, 8 weeks window. 2 weeks different between each specialty, and they all close at the same time. They almost all announce at the same time, and whether you are accepted or not, there is a feedback on your scoring system. Where did you miss, or why you did not get accepted in a certain specialty? So where your matrix was lacking based on the other applicants. So they will always give you this feedback. Why you didn't score an average or at that average of that year for the acceptance of that specialty. So it's your decision after not getting accepted. Do you think based on that feedback, you can improve and apply next year and guarantee that you will have a choice? You'll never guarantee 100%, but are you confident that you can fulfill this weakness in your application for next year? Or you think, no, this is never going to be filled. Okay, I should not waste my time and I should settle for what I have. I cannot answer it straight away. It's again based on the feedback, what you fulfill, where your weaknesses are, and then you can always improve.
Okay, thank you.
Anytime. Did I answer? Okay, just a quick thing. Anybody attended? Or did I answer all your questions in mind? Did I not cover anything that you had in mind? I'm sorry, I tried to gather a lot of things, and it has been a very, very long talk, I know. So let me know.
Doctor, I have one small question. Is there a way to know the previous year's point system for each specialty? Is it like posted online or something?
What do you mean each year?
So for the point system, when we apply to specialties,
I'm not sure صراحة. يعني how many points out of 36 مثلا Thoracic they accepted? I think it should be somewhere. I'm not aware, but it should be published somewhere. But again, don't depend on last year because each year is different. It's based on the average of the applicants. So if your year the average is high, then the average is high. If this year the average is low, then the whole average will be low.
All right, thank you very much.
Anytime. So again, don't get scared by numbers. Work on your own. Like, don't distract yourself. This is my point. What's the point of looking at last year number? But then, what's this gonna add to you? Nothing. Why you wanna waste your time? You're gonna be worried and you're gonna just get distracted. Build your own CV. Focus on what you have. You already have the scores that you need to accomplish. Focus on that. Build your own and focus on your own self. You will get it, I'm sure. Anybody else? And I know how many of you want surgery actually out of the 18, survival 18. بدينا ما كم 30. Oral maxillofacial, good. Okay. Plastic, vascular, good. Orthopedics, cardiac, adult or pediatric, good. Okay. Nice. I hope this helps. And again, you can, everything is online. Focus on the matrix. Focus on the matrix, and acclimatize yourself with the system.
Doctor,
Yeah.
Doctor, can you share with us the PowerPoint and any important links?
Of course, I will.
Thank you.
Doctor, you mentioned that you can show us your personal statement. Can we see that, please, or share it with us?
Yes, I will.
Okay, thank you.
Time. Okay. who is the boss today? المديرة وين?
Yes, doctor.
Yes.
So
Okay.
thank you for the
I'll share,
presentation.
sorry, my accounts and my email for you.
Sure, doctor. You can send it in the chat.
Sure.
Thank you so much for the informative presentation, Dr. Abdullah. I'm sure everyone in the audience found it very beneficial. Though you were sick, you gave the talk. We really appreciate it, and we truly value your experience and your guidance.
Thank you.
I also like to thank AMBOSS for their constant support. To everyone in the audience, thank you for joining us today, and our team hopes that you found this session as informative and beneficial as we did. If you have any questions, please feel free to put them in the chat, or you can unmute yourself and ask your question. Also, make sure to follow us on Instagram, Twitter, and to subscribe to our YouTube channel to receive latest updates about our upcoming events. I will put all the links in the chat. And if you have any further questions or would like to contact us in the future, you can do so with the IO forum. I will send the link to that as well. Thank you, Doctor.
Anytime.
Thank you to everyone in the audience once again, and we hope to see you again in our upcoming webinars. And yeah, have a wonderful day.